Good afternoon. My name is Mariah Peterson. I am attending Liberty University and I'm in the F&P DNP program. Today I wanted to talk about childhood obesity. So, childhood obesity was basically classified by the NIH in 1998 as a chronic disease. The Center for Disease basically stated that the prevalence is actually quite high. 19.7% of young children in the United States are obese, and 12.7% of these children are under the age of 2. And when we're talking about this, it's also important to consider, ethnic groups and high risk group that I found when I researched this was that of Hispanic children, which was at 26.2% prevalence. So when you think about obesity, I think it's something that we don't really consider in the pediatric population. It's not really discussed. However, as providers, I think it's important that we identify this and try to take action just to help improve the quality of life and health of young children so that they have a better chance or a better start. Just some things I've noticed just around my area or even working in the ER is that if you take notice of it, you will notice that there are more children who are overweight, or at the park that there's children that have trouble just trying to play or run around. So it's kind of a sad thing that I've noticed recently. So again, health conditions, obviously caused by obesity are high blood pressure, hyperlipidemia, diabetes, asthma, joint and sleeping issues. And these are all listed by the Center for Disease and Control and Prevention. So with obesity, the unique thing about it is, despite it being a chronic disease, it can be prevented and reversed, which is key as a provider. Most children will present with a BMI over the age-specific percentile, so generally above the 95th percentile. They will be at risk for altered anatomy and metabolic processes. So the altered anatomy, more weight on their joints, their airways, if they're having sleep problems due to increased, neck tissue or adipose tissue on the neck. Again, the airways, more at risk for the bronchospasm. Metabolic processes, they're going to, have insulin resistance, poor metabolism, which will make them, or cause, I guess I should say, other diseases in the long run. So most of the time when a child is obese, there is an adverse childhood event or trigger or the cause. And so it's important to kind of review this and try to assess to see if there's something else going on. So the pathophysiology of obesity is that it causes inflammatory markers in the body, so specifically the cytokine cascade, which triggers a whole slew of other things, including diabetes, heart disease, cancer, increased C-reactive protein. So again, it's really important to try to prevent this. So according to Williams, an article, they wrote that there are several risk factors that they found that essentially contribute to obesity among the pediatric population. The first one is economic status. They found that those children in lower economic households had an increased risk of obesity due to food insecurity, lack of proper nutrition, and the ability of parents to essentially afford healthy food and produce. Cultural aspects, so children of Hispanic ethnicity, most of the time, this is due to the fact that that culture views excess weight as not an issue in young children, so it's not a concern necessarily. So something just to follow up on if that population is part of your practice. Poor sleep is another risk factor. A lot of children today aren't on a schedule or they're not getting enough sleep. So making sure that, we're following up on that. Formula fed infants, this kind of surprised me a little bit, but I mean, it does make sense. They may not be regulated as well in terms of, like if you're being breastfed, a baby is going to essentially stop feeding once, the milk has run out. And most of the time, the mother's body produces and, or meets the needs of that child. And so it's regulated a little bit better. And then oftentimes, parents tend to overfeed infants, not understanding, the size of the stomach and how much an infant truly needs. So that ties in directly to, educating the parents on how much a child should be eating, depending on the age, making sure they're not overeating or undereating. So according to the American Association or Academy of Pediatrics, they have created a clinical practice guideline for screening and evaluation for children 2 years and older. So that is essentially you are using the screening with the BMI. So again, the BMI over the 95th percentile is basically the child is obese. And then I found a useful site through the CDC, and it's actually a BMI calculator. So if you're busy, you can always just pop the child's weight, height in, and it should kind of calculate it pretty quickly for you. I did a couple, and it didn't take too long. So again, the American Academy of Pediatrics has created basically an algorithm that can help or assist the provider at each wellness visit to kind of screen for this and see if the patient has, meets any of these criteria. So it kind of gives you a roadmap of what to do. And I always like having something like this so I can kind of streamline it and use it, on, your pediatric patients. So you're getting a consistent screening first off, and then a consistent result or treatment plan. So screening recommendations continued. Again, you're going to screen for any adverse childhood event, and that can include, things that may stress the child. So parents' recent divorce, any violence in the home, any financial issues. As you know, we listed some of those things kind of tie into the risk factors. And then any mental illness of both the parents or the child if they're having behavioral issues or things like that. So another thing to screen for are inequalities. And then another one that is important is the provider bias. So, oftentimes we associate obesity or weight gain with a stigma, or the child gets labeled, and we may do this unconsciously at our, without even thinking about it. And I think it's something to note, or something to just be aware of, and to make sure we're treating these patients the same, and that we're not putting a label on them. So the role of the DNP in all of this, obviously, is to utilize the pediatric quality measures, so the algorithm, the guidelines, and basically focus on preventative care and screening. So each wellness check, we should be monitoring for this, making sure we're paying close attention, making sure that parents are educated on what is healthy and what is not healthy. If they have financial difficulties, providing them with resources, that falls under the DNP role. And then also to make sure and ensure that well-child visits are being completed and the screenings being conducted, because many parents often will miss well-child visits or fail to even do them. So that's something to also consider, especially with COVID happening and a lot of kids didn't see the doctor for quite some time. So just some thoughts on that, and to make sure that we're doing that as providers. And then again, screening for the risk factors, making sure the child isn't at risk, and screening tests. So always calculating the BMI, making sure it's matching up, and then treatments. And I'll talk about that here in a minute. So again, the focus really is on health promotion. So if we're addressing the social determinants, providing resources. A lot of the times with, if a child's obese, there's a lot of family behavior too that can, or that may need to change. So making sure the family is really involved. There's two programs here listed, the IHBLT program and the Bright Bodies, basically as a family-based program to help incorporate healthy nutrition and light exercise to help basically the whole family be healthier as a whole, which in turn then helps the child. So again, health promotion, continue, things you can do right off, if you have a patient that, you've seen for a while and they start a family, and, you can encourage, breastfeeding, provide education on the benefits of that, encourage nutrition, what are nutritious foods, what aren't, mainly, foods that are not processed, and then making sure that they are involved in the community, and that the community is involved in the resources they're planning for, meeting families who may have needs. A lot of times I've seen, like the community gardens or, local things like that where the community members all work together, and then they, can kind of reap those benefits. So guidance for parents, some things that just kind of come to mind. Encourage family dinners at least twice a week. This is according to Bright Futures. Really, sit down and enjoy a meal together. Provide healthy, nutritious meals. It helps support development, obviously cognitive development, and ensuring as the child becomes older that they are aware of healthy choices and options, and that they are given that choice and encouraged to make that choice. And then also, depending on the age of the child, it's very important to, make sure you go over the milestones of when you should be starting your cereals, when you should be introducing food, self-feeding for the child, and then going over, foods that are high risk or choking foods. So nuts, gum, popcorn chips, carrot sticks, grapes always need to be sliced in half. Meat needs to be chopped, because they obviously, sometimes they don't have teeth, or if, they do have teeth, it's hard to chew. Hard candies. So just these things may seem simple to us, but at times, parents may not think of it. So it's always good to make sure you go over it. And then again, education on normal weight gain. So, an infant roughly 500 calories in formula or breast milk a day. And then, by early childhood, they should triple their birth weight. And then, middle school, around 7 to 2.5 inches per year. So, there's a lot of parents out there, who want their kids to be a little chubby or a little, overweight or obese, or they may not think of it, and encouraging them and reminding them that, hey, this is something that we need to make sure is screened for and kept under control, because it can have pretty negative health consequences on the child in the future. And then, making sure that they understand fats are not restricted during the first 2 years of life. And again, the iron fortified food. So after the first 4 months of life, they need to have, start on cereal, obviously, if they can sit up and they can hold their head up. So making sure they understand the milestones for that. And then again, going back to breastfeeding, which really, there's multiple studies out there have shown that it lowers the risk of obesity, because it really helps regulate the baby's true need of, what they need calorie-wise. So again, you can even go over these with the parents, ensuring that they know what a healthy weight is. So, less than the 5th percentile is underweight, greater than the 5th, but under 85 is healthy. So that's what we're shooting for. And most pediatric offices have, the parents have the ability to access and review the notes, and sometimes even the growth charts. So most of the time they can actually see this, which may be helpful. And then greater than the 85th percentile, they're going to be classified as overweight, and then greater than the 95th percentile as obese. So again, creating obtainable goals and making sure that parents know excessive weight is not healthy. So I think the spiritual aspect in all of this as a DNP is that God calls us while we are here on this earth to take care of our bodies. And as 1 Corinthians 3:16 states, do you not know that you are the temple of God and that the Spirit of God dwells in you? And so I think that's just a good reminder for all of us to really take into account our bodies and to try to stay as healthy as we can and be conscious of what we're putting in our body and giving to our children. And that should overflow into our practice. And so we should care about this for our patients and their children, those with whom we work. So setting that example, I think, is important. And then also tying that with, as Matthew 9:36 states, having compassion on those around us and those who we treat, so that they can, feel essentially the extension of Christ's hands and feet, and doing it in a loving way and not in a judgmental way, or as we had talked about earlier, the biases and labeling, anything like that, but just kindness, compassion, and true caring for patients and their children, and wanting the best for them and the best potential life. So thank you very much. I will have my references here. Most of them were from Bright Futures and the CDC, which had a lot of very helpful resources. So definitely we'll be utilizing those as a provider.